Well, good afternoon, everyone. Like I said, it's so nice to see so many familiar faces. It's time to grab a cup of Java, and we're about to start a great conversation with Dr. Harlem Gunness. He is the director of the St. John's Public Health Program. He has had a long-standing career in public health, serving community-based organizations, hospitals, local and state, federal health departments, private industries, and universities. And prior to St. John's, Dr. Gunness was the senior officer with the Public Health Service stationed at the CDC, the Center for Disease Control. And he worked in the Division of Global Migration and Quarantine. So now I will turn it over to you, Dr. Gunness. I want to thank you so much for taking time out of your busy schedule. We will be sending you a thank you, and in the thank you, we're going to include, Dr. Gunness just told me that Brian Brown interviewed Dr. Gunness, and there's a YouTube video on that as well. So as a follow-up, we'll send you that interview too. But if you can spread the word about our Power Hour series, it's going to be great every Tuesday at 1 o'clock to meet up and, like I said, have great conversations. So I'll turn the floor over now to Dr. Gunness. Thank you.
Thank you so much, and it's a pleasure and a distinct honor to be here to talk about what's happening with the pandemic crisis. As Susan mentioned, based on my background and experience, I've done pandemic planning and disease surveillance of highly infectious diseases, and been working to really prevent the introduction of diseases in the U.S. So public health is very passion for me. And in sort of thinking in line with the mission of St. John's University and the, its efforts to address the needs of the poor and underprivileged, I think that it's important for the public health program for us to sort of look at and examine Queens as one of the hardest hit neighborhoods, and to see what are the factors that maybe, or the reasons behind it became the epicenter of the pandemic in the US. So if you would allow me, I would share with you some of my preliminary findings on some descriptive data and analysis that I've been doing. So let's begin. So I just want to give you an overview of the presentation today. We'll just touch on the current situation in the US, New York City and Queens, and then sort of hone in on Queens to look at what's happening. And talk about things that we may know already in terms of transmission and prevention of COVID-19, and I'm comparing the demographics in communities with high rates of COVID-19 versus communities with low rates of COVID-19. And look at sort of the social determinants of factors such as the rent burden, or overcrowding, and the health of these communities in general. And explore some public health interventions beyond social distancing and the wearing of masks and hand washing. And then I'll open up the forum for questions and discussion at the end. Okay. So I just want to preface before I begin the discussion, that with any emerging in novel infectious disease, that the situation and things change rapidly. Therefore, new information as it becomes available may require, or it may change some of what I'm talking about today and presenting. And a lot of the information that I'm sharing with you, the content in terms of the rates and the demographic information, was based on CDC and New York City State Department of Health and Mental Hygiene's website for the past week. I should say New York State and New York City as well. So when you look at the current status, this was based on last week's results. So we see that globally, the COVID-19 is dramatically affecting Europe as well as the United States. Um, and as we know, it started off in Wuhan, China, and then rapidly made its way to the Western world. So as of last week, we had over 2 million coronavirus cases and over 135,000 deaths and over 500,000 who have recovered from the virus. So when you look at the worldwide statistics, we have, again, 2 million. In the US, we have 644,348. And more specifically, when you look at the death and you look at what we call the case fatality, that is, of those who are infected, the amount of, or the percent of patients who die out of those who are infected. So globally, the case fatality rate is approximately 6%, and in the US, the case fatality rate is averaging at 4%. And that case fatality rate may vary by community as well as region or urban areas or different geographic areas as well. So here in the US, we see that disease is really affecting or started in the coastal areas and urban areas. And you see the very dark red where there we have over 5,000 or more reported COVID-19 cases. So when you look at New York City, this is a map that shows the COVID-19 cases throughout the 5 boroughs of New York City. And this was from last week. So you see that the dark purple areas are those areas that have a very high incidence of COVID-19 cases or rates. And it's distributed by the zip codes in communities. So now let's talk about death, right? Because as much as people get ill from COVID-19, they may recover, and we have a large number of people who are recovering. However, when you look at the death rates here, you see here that those who are dying, there's a dramatic percentage of those who die that had an underlying medical condition. So we see here the age group that it's affecting dramatically are folks who are over 45 years old and older. And you see here as well that males are also dramatically affected by death as well. And in Queens, even though Queens is the second largest population out of the 5 boroughs, Queens also have a high rate of death as well. So when we think of underlying medical conditions, we're thinking of conditions that are often that can be manageable or reversible in some cases. So we're thinking of diabetes, heart disease, hypertension, those who are older, those who have immunocompromised conditions such as cancer, and those that may have a liver disease. So it's really affecting our essential organs. So what do we know about coronavirus? We know that it belongs to a large family of viruses that's often found in camels, cats, civets, bats. We know that it's on rare occasions that the disease can spread from animal to infect people. And we also learned that now it's spreading, and that's a big concern, that it's spreading from people to people. And the coronavirus belongs to a family of other viruses, such as the Middle East respiratory syndrome, as well as the severe acute respiratory syndrome viruses. And it's now called the COVID-19. Now, I just also want to mention that when the MERS virus and SARS virus occurred, a lot of studies were done on it to show that it was also affecting or killing those who had underlying medical conditions. That's something to remember as we continue our discussion today. clinical definitions for COVID-19 are based on what is known and what they use for MERS as well as for SARS. And CDC has adopted those definitions as once the virus COVID-19 was introduced in the US in preparation for planning and response and for treatment as well. So there's still a lot to learn about the transmittability, the severity, and other factors associated with COVID-19, and investigations continue. It's ongoing as we speak. We know that it's transmitted from person to person, those who are within 6 feet proximity to an infected person. We know that it is mainly through respiratory air droplets, similar to the way TB is also transmitted. And it's also important to note how easily the virus spreads from person to person. That can also vary.
Dr. Gunness, I'm sorry to interrupt, but I'm getting some messages that the sound is a little choppy. Do you have your earplugs? Because that might make it less, it might be clearer if you maybe use your earplugs.
I do not. Actually, I do not have earplugs.
Oh, okay.
Yeah, I'm sorry. I do not have earplugs.
I'm just trying to see if everybody can still hear you clearly. Is it getting better? Because I know for me,
I have no problem.
no. Everybody's okay? Okay. All right. So maybe the sound is getting better. Sorry about that. Sorry to interrupt.
Oh, no problem. So we know that what we did on the federal level was to prevent the introduction of the disease. We tried our efforts to do that by banning flights from affected areas in China and Europe from entering the US. But what happened was the virus was already here and already started to spread in the US. So it now became from, even though we tried to prevent it, since it was already here, it became sort of a community related type of issue where now it's spreading from communities to communities, from person to person, and then it's now all throughout the US. So what do we do now that we have one? So let's focus in now on Queens and let's look at what the population density is. So as I mentioned to you, in New York City, Queens is the second largest in terms of population density compared to all the other boroughs, Brooklyn being the first with the largest population. So when you look at the age distribution in Queens, you see that we have a high percentage of those who are in their sort of middle age or between 25 to 64. When we look at race, we also see that there's somewhat an equal spread among the different races, and it's very diverse, I should say. Now, when we look at Queens in terms of foreign-born and in terms of those with poor English proficiency, we see that we have about 50% of Queens residents who are foreign-born, and we see that we have about 29% of those that struggle with understanding and speaking English. That's something to consider as we go along as well. When we look at the educational levels, we see that a larger percentage of our Queens residents have a high school diploma or more. However, we will see that we have 19% with less than a high school diploma. So in terms of, just want to go back to this slide, in terms of social determinants issues, these are some of the factors we have to consider as we look into and we hone in on the communities that are dramatically affected by COVID-19. So here is the rate of COVID-19 cases, specifically in Queens, and it's saying that we're at a rate of 16 per 1,000. So out of 1,000 people in Queens, 16 people are more likely to get it. So let's look at Queens now and let's look at communities that have been affected. So I selected 8 communities, and this is just preliminary data analysis. This may change over time, but for now, I wanted to see the areas that have low cases of COVID-19. So I looked at Astoria, Forest Hills, Flushing, and Bayside. And then I wanted to look at the areas that are dramatically affected, that are the epicenter, the ground zero, if you will, of COVID-19. And I see that Elmhurst, Jackson Heights, Corona, Jamaica, and Far Rockaway. So this is an interesting slide. So here it shows the population of these 8 neighborhoods. And as we go along, you'll see that the red bars are the neighborhoods that have the high COVID cases, and the green bars are the neighborhood that have the lower COVID cases. So in the bars here, you see that the population density is, the chart is on the numbers on your left. And on your right, it's the COVID cases, which is that zigzag line that you see here. So when you look at the population density here for the COVID cases, you'll see that though the neighborhoods that are dramatically affected, like Jackson Heights, Elmhurst, and Corona, you see this here where the peaks are. These are the neighborhoods that have very high influx of COVID-19 cases. And you see in the neighborhoods where there is even though like in Flushing, you see a high population density, you still see that it's significantly lower compared to these other communities in the red square box. So again, looking at the population of the community districts, you see here that there are some similarities in terms of the population size. So when you look at Jamaica, for instance, and compared to Flushing, the numbers aren't that far apart. When you look at Corona, for instance, which is a dramatically affected severely affected neighborhood, and you compare that with Astoria, the population density is really not that far apart. So let's look at the age distribution in these communities. So the red box again are those neighborhoods that are infected, have high, severely high cases of coronavirus. So you see here the age demographic in these neighborhoods, such as Elmhurst, Jackson Heights, Corona. There's a large number of people who are in their 20s and through 40s, right? Mid 20s through mid 40s. Also, too, here in Astoria, you see it's significantly high, but yet in Astoria, you do not see it being, they have less cases than these other neighborhoods here in the red box. Also, when you look at 65 plus, we know that some of these communities, such as Flushing or Forest Hills, Bayside, they have a slightly larger number of those who are older. However, in the slightly older population versus the communities that have severe cases. So when you look at the race categories in these neighborhoods, so again, the square box, you see that we have a significant amount of specifically Latinos and Blacks in the communities that have a high cases of COVID-19 versus the communities that have lower cases. You see that it's a significant percentage of Asians and whites. Now look at the communities that have less than a high school diploma. So remember a few slides before we showed that in the borough of Queens, we have those with less than a high school diploma made up 19% of the population. So here you see when you compare the communities that are dramatically affected compared to those that are not, you see that the communities that are dramatically affected have significantly, they have a larger number of them are less educated, such as Corona or Jackson Heights, Amherst. Now, in terms of poverty as well, you see that again, the epicenter, the ground zero of the disease, you see that in Jackson Heights, Elmhurst, and Corona, they are, more poor than other neighborhoods as well. Now, let's look at the insurance and access to healthcare. So one of the key indicators that I wanted to look at is whether or not these neighborhoods have access to healthcare. And one of the specific variable that I want to look at is whether or not they have insurance or not. So you see here, it is a dramatic difference in the Jackson Heights, Elmhurst, and Corona neighborhoods where they do not have access to healthcare. And this is the proportion or the percentage of the population that do not have access. Now, when you look at the average number of uninsured versus so what I did was I looked at the 4 communities that are dramatically affected by COVID-19, and I did an average of the percentage there. And then I also looked at those communities that have lower cases of COVID-19, and the average there as well. So when you look at the average of the uninsured, you see that the communities that have high cases of COVID-19 have almost double in terms of the number of those or percentage of those who are uninsured compared to the communities that have lower COVID-19 cases. So let's look at the number of avoidable hospitalizations. So the way the New York City determine avoidable hospitalizations is that it's when patients present at the hospital for a disease that can be prevented with access to primary care. So you see here that in the highly affected communities, that they have more number of avoidable hospitalizations than the communities that have less COVID cases. Also, I want to point out, throughout the slides, you see that Flushing outnumbered in terms of age demographic, in terms of population density, in terms of race. And you see here, in terms of the number of avoidable hospitalizations, is significantly low. Now, when you look at the average, again, averaging the avoidable hospitalizations between the heavy impact community and the low impact community, you see that communities with a high COVID cases have 33% more of avoidable hospitalization than the communities that are less affected. So let's look at the foreign-born and the limited English proficiency. So when we look at the Jackson Heights, Elmhurst, Corona area, you see that there is a sort of a parallel line here with the significance of those who are foreign-born and those with limited English proficiency, right, compared to the other neighborhood. Now you see this again, it's very similar in Flushing as well, right? But it's dramatically different in the other communities. When we look at chronic diseases, remember when we looked at death earlier in the previous slides, we looked at the disease that are causing death, underlying medical conditions such as obesity, diabetes, and hypertension. You see here again, look at Jamaica, we have a significant number with hypertension, Far Rockaway, Corona, as well as in Jackson Heights, which is not the same in the less affected communities. Also, when you look at obesity too, you see these rates are higher compared to the other communities that are less affected. So another issue that really stands out a lot is the severe overcrowding. And when you look at the data on severe overcrowding, you see that Jackson Heights, Elmhurst, and Corona, Queens are dramatically overcrowded compared to all the other communities that were examined. So this is a classic example of, for those of you who would remember the tenement housing, this is one of sort of the picture on these densely packed, concentrated tenement housing in the Lower East Side in the early 1900s, and they were made up of immigrant communities who were arriving. And one of the issues was that it was really a breathing zone for infectious disease like typhus fever and cholera and TB. And it was due to again, the limitation in space, air, and light and breathing room, if you will, in these communities. And as a result of that, it led to the change in the urban landscape in terms of how we develop and design space for us to live in. And this is sort of a modern day densely packed housing community that you may find in some of these heavily affected neighborhoods like Corona, Elmhurst, Jackson Heights, or even in Jamaica, you'll see that as well. So in conclusion, what are we seeing here? So we're seeing that the less affected COVID-19 communities are more educated. They have significantly less overcrowding and also heavily widened Asian communities. And those who are heavily affected by the COVID-19 are communities with severe overcrowding, severely uninsured, elevated chronic disease conditions such as hypertension and diabetes, which is leading to death in some cases. And they also have more avoidable hospitalizations or disease that causes hospitalization. And also it's heavily Latino and Black. And that is the end of my presentation today. So I would open up the floor.
Yes, we can open up for your questions now, but thank you again. The numbers are staggering. It's unbelievable when you look at, these slides. You really see it in its true light. I know we had talked about, ironically, last year during reunion weekend, I had a walking tour through Corona and Jackson Heights. And we saw firsthand what the community, a very vibrant community. Like you said, dominance was Latino from all different countries. We were talking about in terms of, food carts. That's where they get their source of food, bodegas. I know you touched upon in our last conversation. Maybe you might want to share some of your thoughts about that. But really, it seems like history repeats itself, that we still have the tenement style living, and we know that that's not conducive to a good living situation. And now we're here with another pandemic and having the same situation. So as a public health official, how do we overcome this? How do we make politicians or people who do development, how do we make them realize that we really have to develop better living quarters and more affordable housing for families?
That's an excellent question. And I may not have a specific answer to the question, but I think that to address the issue at hand, right? So if there's a tiger in a room, we got to think about what are we going to contain that tiger, right? Or lion. So with regards to the lion in the epicenter right now with the disease that's affecting communities, I think that there may be some interventions that, or radical interventions that we can do to mitigate the spread or reduce death or severe illness from the disease. So a good example of that is when we did the Ebola response at CDC, we had every passenger that we saw that came from an affected country, we gave them a kit. And in that toolkit had instructions on how the disease is spread. It had a weekly calendar to monitor your signs and symptoms. It had a cell phone for them to call their respective health departments at their final destination. Now, I'm not saying that we give everyone a cell phone, but what we can do is that if an ill person presents at a hospital, what we could do is that we can then reach out to whoever they live with or whomever they work with to inform them that, you have been exposed without disclosing the name of the patient. and that these are some of the measures that you can take to prevent yourself from getting the disease and your loved ones, or if in the event that you were to experience these signs and symptoms, follow these steps. If that makes sense.
Yeah, yeah. But as a community like that, social distance, they're telling everyone social distance. You saw that picture as family social distance. It's impossible.
Right. So that's the other thing too that you can assess. You can assess, say, I present at the hospital with a disease with COVID-19 signs and symptoms, then we can have someone perhaps call and assess, can you socially distance yourself and your loved one? And if you can't, then perhaps explore other options about social distancing or other things to wear, PPE, or other things that they can wear or things that they can do. It seems impossible, but I'll tell you this: 10 years ago, when we were planning for a pandemic down in Miami Airport, these were some of the issues that came up. And we have to be creative and we have to be innovative in how we
Yes.
deal with it. And it's really to protect ourselves and our loved ones and our community. So I believe that there are solutions that we're going to learn from this experience as well.
There is a question someone typed. They were diagnosed with the coronavirus 2 years ago in November, and the doctor determined that it was caught from teaching at a New York City campus. And the person says it took a while, but I got better with rest and heavy doses of vitamins. But would I have antibodies to the current coronavirus?
So that's an excellent question. So again, the coronavirus belongs to a family of viruses. So I would need to know more specific details about what type of virus it was, the type of testing that was done, and whether or not this is the COVID-19 is a very new strand. So more than likely it may not be, but we're still learning. So it could have been in the community and we don't know it. So there's a lot of things that we need to know, and also similar with the flu vaccination. We get the vaccination to immune us from the flu from last year, not the new flu, if you will. So
interesting. Does anyone have any other questions? You can unmute yourself if you want, or you can type your question. I think Dean Fagan, your question was answered, correct? I don't know if he went on, if he's with us.
Yeah, that was correct. He answered it a few slides later.
Oh, okay. Anyone else have any questions? I would say, I have another question. St. John's University is in Queens, and we are kind of like in between some of those areas that are highly dense in terms of coming back, doing a rollout. What would be some of your recommendations in terms of how we social distance on campus to prevent ourselves from contracting the virus?
I think it depends on the situation at hand, whether or not we can quote unquote flatten the curve, and whether or not we can see a decrease in the spread of the virus in Queens and other, in other areas in the U.S. I think that what this virus has taught us is sort of basic skills that that we know already, right? Like hand washing. I think that right now, and again, as new information becomes available, then they change the guidelines and recommendations. So now they're recommending that everyone wear masks when they go outside. And the purpose of wearing a mask is not to protect you per se, unless you have a medical condition or underlying condition, but it's also to protect someone else. So in the event that you may have had it, or you have the symptoms, you may have the disease but not have the symptoms, then it protects them. You wear the mask to protect someone else from getting it.
All right.
So that's the reason. So I think, and this sort of ties in with another question too about whether schools will be open or not. When you're dealing with a pandemic and you're dealing with a disease that's killing 5% of the population, unless we have the ability to manage that or to reduce that, then I see maybe a potential for schools to open, in September in the fall. But if we do not have that ability and capacity to do that, right now we're seeing that it has inundated a hospital and healthcare system. And I know that there was a question about those who are dramatically affected in nursing homes. And the reason why it's happening is very simple. The elderly population don't have a strong immune system as we do, and may not be as mobile to walk around to exercise their lung. One of the key factors of the things that's killing a lot of folks is that they get a severe type of pneumonia. And that's why it's really affecting nursing homes, unfortunately. And it's a very sad situation and that's the problem, and that's what we're trying to avoid. So, my mother-in-law is currently now in a nursing home, and for me, I can't go see her, and she can't see us. But say if I have the virus and I had no symptoms, and then I present at the nursing home, then what happens?
Right.
And that's what you're seeing, throughout these stories over and over again. Where someone may have the symptoms or may have very light symptoms. The scary thing about this disease and that we're learning is that it is really sneaking up on healthcare professionals in the sense where someone may present and have very mild symptoms, and then in a matter of days, they just get terribly worse. Or someone may present with very, severe symptoms.
So are you pro-test for the testing then? Do you feel that that's the solution? If we test everyone?
I think, if we have the ability to test everyone, I think that that's great. But there's also another thing to consider when you think of testing: the validity of the test, the tool, and the precision of it. So, as much as we want to rush to get the testing, and there's a lot of anxiety, and we know that, and we're all experiencing it. We need to try to get the test that can give us some accurate results, and not have people go, in more panic or more, go stir crazy. So, if we do have it, by all means, if we can afford to have it available, then we can do that as well. So, that's another way to address the issue, right? To determine whether or not we have it, whether we have developed the antibodies. I see another question here. You see this question, Susan? Isn't our location
It's our
between two
location,
major-
right?
So,
Isn't our location between two major airports, coupled with vertical living, an issue with potential exposure to this virus?
that's
Very
a
real.
very good
Yeah.
piece, And these are the issues that are compounding it further, where because we're in proximity to two major airports, we're actually between two major airports.
Right.
And a lot of the families that are affected who are those who are cab drivers, are delivery workers, who are sort of entry-level service workers who work in these industries as well. So you can see there's a propensity for the disease to spread in these communities.
And what about the subway system? I mean, a lot of the families that you're mentioning, they're taking the subway, and they did mention that the subway had a lot to do with spreading the virus.
Absolutely. So think of it this way. Think of anything that's in congestion, right, or overcrowding. That's how the virus spreads. So going back to the question you had earlier, Susan, where in our discussions, in our early initial discussions when we're talking about this presentation, I mentioned to you that the ratio of supermarkets to bodegas in these highly affected communities are significantly high. For instance, in Corona, Jackson Heights, Elmhurst area, for one supermarket, they have about approximately 15 bodegas. So, what is that saying? Do people access the bodegas more frequently? And if they do, are they in cluster and are they in groups? Are they, close to each other? We know that supermarkets have a social distancing policy at the aisles, but we don't know to what degree or to what extent that the bodegas have done that or are doing so. So when you think of the spread of disease, we got to think of congestion and overcrowding. And for those of you who know Queens, like the way, I grew up in Queens, and I know all these neighborhoods like the back of my hand, there's a lot of overcrowding and congestion that may not be present in the data. So these are the things, are the factors that we need to consider, to reduce or to mitigate the spread of the virus.
We have another question here. Currently, some studies are showing many more people were exposed to the virus, but as you mentioned, Dr. Gunness, they didn't show any symptoms, so the death rate can be under 1%. So wouldn't practicing social distancing still assist to allow us to open up our area?
So that's a good question. So when the studies that are showing that you mentioned, where those who have been exposed to the virus but had no symptoms. So as of right now, we do know that some folks may have the virus and not be symptomatic. But can they then now spread it? So these are the things that it's still unknown, right? Where we're still trying to sort of figure out the details of this virus and how it's spreading and how it's not spreading, and those who are symptomatic versus those who are not symptomatic. So as Susan mentioned, if we do have the testing available, then we can then look at it to determine, like, those who already had the disease or are immune to it, and to what degree can we then spread the disease? Is it just exclusively for those who are exhibiting the signs and symptoms, and you cough in my face, that's how I get the disease? Or are there other means of looking at it? So great question. Great question. So there's also that fine line between the social distancing and opening up the area, right? So, they talk about opening up the areas and they talk about social distancing. And, these are some of the things that we need to consider. If we were to open up the areas, then to what degree do we open up the areas? If we do have a death rate of under 1%, as is the case with the influenza, the common flu that we get every year, then to what degree, and who makes that determination where it's safe to open up the spaces or the area if we have a certain percentage of death, right? These are all sort of the public health authorities and the government agencies for them to determine if and when should we then open up, universities, schools, stores, etc.
So maybe that answers the person's question that says, do you think the schools, the universities or all schools, can they start again in September? So it's really based on everything that you just said.
Yes, and someone just asked a really very good question about those who died from COVID had the flu vaccine. Is this a causal relationship between the two? I can't answer that because we haven't run the studies to determine whether it's a causal inference or not. So that's an excellent question. Also, we don't know whether or not we have the medical documentation to assess whether all of those who have died from the COVID-19, whether they had the flu vaccine or not. When we look at the data and when we look at the communities that's been affected, which are normally the poorer communities or the communities that are undereducated or uneducated, chances are if you compare those communities with those with flu vaccination, they are less likely to get flu vaccination as well. So that's where some of the things that we need to sort of consider whether and to determine whether we can have see there's a causal relationship between. Very good question.
So I have a question, sort of an extended one from that question. So I'm thinking, say we do go back to school in September, and usually people start to get, flu symptoms October, November. Now, we don't have the vaccine for the virus. Now we have the flu and the virus. Does the COVID virus come on stronger now? What's the expectation of the new wave? Does it come back or it doesn't come back at all? And then what happens now that we have that on top of the flu? How do we control all of that, in other words?
Right. So we're looking at two different animals, right? So say we can, there are two lions in our room. So, if we have two lions in our room or in our community, then what happens next, So I think we have to sort of consider the wave of the virus, right? So I'm reading and I'm hearing that it comes in waves. So this is the first wave. So let's see what happens after this first wave, what the second wave is like. Now, we do know for the influenza vaccination and for influenza, we do know we can run the test to see whether or not it is actually influenza or not, right? Hopefully, we'll have some sort of enough testing for us to do the same similar tests for the COVID-19 to see if we have one or the other, right? But the other thing to think about is those who may not have the symptoms, right, and may not have testing, and may not have the access to testing, and then what happens then? So, we talk about herd immunity where, where the large majority do have, or where they have vaccination for a disease where it reduces the spread of the disease. But we also know, as in the case with measles, where some communities who do not believe in vaccination for whatever reason, then you see an outbreak of the measles disease in communities throughout New York City.
I don't know if we answered. I know we were talking about the nursing homes. The second question to that question was the death rate for those homes.
I don't know. I don't have access to that information in terms of the death rate, and all that information will become more and more available. So once it becomes more available, then public health researchers and practitioners will then start to do the analysis to see what the death rates are. But we do know that those who are older have a greater chance of death, unfortunately, because of this virus.
Is that something that, when things get better, they might start to look at how a nursing home is set up? Because I know I have an aunt and uncle, and they just have to stay in their room all day long. I can't imagine mentally, their mental health, what that's like, not to be eating with the people that they live with and just being alone in a room in four walls almost all day long. And then health-wise, not getting that physical activity that they should, and the mental stimulation. So if her nursing homes are shown to have these high death rates, and is that something that you think they'll look at and kind of redesign the way they?
Yeah, absolutely. I think that the good part of the nursing home is that quite often, you may have just one or two patients in a room, which really helps with social distancing.
Mm-hmm.
And I think that it's already sort of made up in such a way where people are sort of separated. I haven't been in a nursing home in a long time, mm-hmm. But I think that there are definitely ways. I mean, this virus, this pandemic will revolutionize the way we look at things, the way we deal with things, the way we deal with diseases, the way we treat each other, the way we connect, and will also challenge us to also think of how to become more creative in our little social little bubble in the event that this were to occur. I mean, thankfully, we have social media where we can have these forums where we can talk and we can, connect with people. But, in 1918, when the pandemic influenza occurred, that, they didn't have these resources and these options. But on that note, we have to think about, we have these resources and we have these options. And why is it dramatically affecting the US compared to any other country in the world?
Question. Another question I don't know if we addressed here, it's like, do we have examples of education that have effectively reduced the level of hypertension, diabetes, and other chronic?
Yeah.
Mhm.
Yes, yeah, there's a lot of research on chronic diseases, and I don't have that information on me right now or handy, but there's a lot of information, and I will share with you my contact information. Do you have it, Susan? You could share with them
Yes,
at
we
the
will.
end? Yeah.
Okay,
If you
great.
have questions or if you'd like to talk about this some more, it will be my privilege to talk to you and to share with you some of the things that we're doing. Again, public health, this program, it's a relatively new program at St. John's University, but as you can see, it speaks so much about, caring for the poor and the underprivileged and those who are elderly. And there's such a need for public health. And, one of the, my passion, as I, mentioned to you, is in public health. And that's what I want to convey to the St. John's University community and beyond. That you do make a difference, and you do see the difference that you make in improving health and saving, your elderly grandmother or your ill parent in a nursing home or in a hospital. And it's through public health and through the research, not just treating a patient, but looking at the mass amount of those who are ill and looking at the epidemiology of the disease, the distribution of the disease, running the research, seeing what treatment works, what treatment doesn't work. How can we, in the U.S., then prevent it from, spreading, or what interventions can we do to mitigate it or control it? I think we have another question here.
Yes. Isn't it true that the USA is doing more testing than any other country? So that is why our numbers are higher.
Absolutely. That's a very good point, that we do have the opportunity for us to do the testing and for us to determine whether or not, our citizens or residents have the disease. So therefore, you may see the numbers that are significantly higher than other numbers. But I think that the testing is great that we have it, and as more becomes available. But I think beyond that, what happens with the 5% that dies? And how do we then address that? And what do we do with that data? So 5%, which is, a large proportion of that 5% will be those who are immunocompromised or those who are elderly.
Years ago, after the swine flu and SARS, SJU had sanitizers on walls and giveaways, and then it stopped. If we return, should we go back to that?
Well, that's a very good question. And I remember I was working at CDC at Newark when the swine flu first came out, and what the sort of the interventions that we had to do there. And that's a very good point. I can't speak for the university, but I can tell you as a public health practitioner, having read the guidelines from the Centers for Disease Control and Prevention on what universities should do, I would say, I would say that St. John's University has done an incredible job with adhering to the guidelines set by the Centers for Disease Control, as well as the New York City Department of Health. And in fact, I've been in contact with two of my very good friends who are assistant commissioners at New York City Department of Health, who, when it started to, affect our communities, said that this information will be readily available to universities on guidelines. And I must say that St. John's did a remarkable job with intervening, with making decisions to socially isolate, to do remote teaching, and they're doing the best that they can within the capacity that we have. So good point. Also, too, I can't speak for St. John's in that sense, but I would imagine if we were to open up that there will be some sort of resources available to reduce infection, i.e. hand sanitizers, things of that nature.
We have a minute left. I don't know if anyone else has any more questions. I think I have one. I have actually one last question, and it has, what's the likelihood of developing a vaccine? And, you know, everybody talks about, you know, someone's like, oh, we're going to have the vaccine by July. You know, some people say a year, some people say 2 years. In terms of effectiveness, how soon do you think we could come up with a vaccine? And with the data that was withheld in China, how do scientists develop a vaccine with not having all the data?
Good question. So let's put China aside, because it's here now, it's here in our communities, and it's here in our backyard or in our homes. So we do have the availability of testing, as someone mentioned, compared to any other country in the world. So let's look at the vaccination. So the FDA is the federal government agency that's responsible for overseeing vaccination policies and clinical trials and releasing vaccinations that are proven to be effective. So they have, I think they have, don't quote me on this, but they have the ability to relax the regulations for the vaccination so that such that it becomes available quicker than their normal sort of not protocol, their normal time span or duration. So number one is the agencies that oversee it. Number two is, you know, the amount of people that we can vaccinate to see whether the vaccination works or not. So how do you know if the vaccination works?
Right.
Right? You have to then be exposed to it to see whether or not you're going to get it or not. Right? So it takes time, you know, for these disease mechanism and characteristics for us to sort of determine whether it works or not. I'll give you a classic example. Working to do disease surveillance and investigation on multi-drug resistant tuberculosis, it takes time for the bacteria to develop for us to know and to determine whether or not that patient actually has multiple drug resistant tuberculosis, right? I don't know what's the case with the COVID-19, but these things take time for us to understand and determine whether or not it's effective or not. So usually from my knowledge or my experience, the FDA normally may reduce the time to about 2 years. You know, we do have investigational drug that we can release that's not on the market per se, but I don't know if this pandemic will revolutionize federal policies on how we deal with vaccination,
Right.
how we release it, and how we test it and make it available to the public.
We actually are getting more questions here. If you don't mind, let's answer those. Oh, Alan saying there's a compliment for the choice of subject. This should be a major focus for SJU to educate the public and provide expertise in this uncharted area. Good point. And next one, International Society of Pharma Engineering, SPE, has a seminar tomorrow on the subject of vaccines. Next one is, we have a campus in Staten Island that does not have conditions of Queens with smaller classes and widespread campus, etc. Could Staten Island open if Queens did not?
Good question. So again, it will be the decision of St. John's University to decide what to do and how they should go about opening up campuses. They may, I don't know, you know, I can't speak for them, for administrators, but we don't know if maybe that can be a potential as well, where if it's a smaller class size, it's more manageable, where you can spread out into a 6-foot distance, whether or not we can, or do we want to take those chances? I don't know. You know, so these are some of the things that we need to think about, especially as we learn more and more about the disease and how it's spread, and symptomatic versus asymptomatic and things of that nature. But that's a great question.
It is a good question. Yeah, I was on a webinar. There was a doctor from New York Presbyterian who was on the front lines, and he said that if you're in a small area for about 30 minutes with someone that's infected, that's when you have a good chance of contracting the virus. So when he said that I immediately was like, how could anyone, I know a lot of these public schools have so much overcrowding. So if that's the case, I mean, how do students, 30 or 40 students in a classroom, how can they possibly be in this enclosed setting? Because it does, right? It would be a potential risk. Unless, like you said, unless we really knew whether they had the immunity, maybe they had the virus already, or they were tested and it said that they didn't, they tested negative,
Mhm.
then it would be okay for them to enter into that room, correct?
Yeah.
No.
Mhm. And then
Very
it
tricky.
becomes an ethical issue whereby, so are we saying now that those who are tested negative can go to school, and
Right.
those who are not tested, who are not negative can stay home?
Online.
To what degree they
Right.
can stay home, and what
Mm.
about if they're symptomatic versus if they're asymptomatic? And you know, there's a lot of things we have to think about with a new novel disease, and these are stuff, we're living it and we're breathing it and we're experiencing this. And I think that what we need to do is to really think about creative ideas and creative ways to help each other and help our communities and help our neighbors. And and another example I want to share with you is that in terms of the messaging that was sent by the public health authorities, um, I noticed a lot of messages were sent via social media, right? We have Twitter, we have Facebook, we have LinkedIn, we have et cetera, et cetera.
Right.
What about the poor and the elderly? What about the cab drivers who don't have social media or don't look at the news because you're so tired coming home from driving that you just can't sleep to get up to go to work again? Or what about some of the other communities that are affected that may not look at the sort of standard sort of, prime time, TV or shows or whatnot? How are they getting that message? And are they getting the message that we want them to get? Are they getting the quality of messaging? And are they getting the message in real time as it becomes available to us and it changes for us? So these are a lot of things that we need to sort of consider and think about, when you look at a disease and a disease of public health significance.
So education is key.
Yeah,
Educating the public is really key.
absolutely.
Well, this was terrific. Thank you. There's just, like, I think I told everyone in the start, there's just so much that we can ask. And like you said, we just keep learning every day, you know, for ourselves on how we can survive, through this pandemic, but also the scientists, everybody, leaders on the best way to deal with it and the rollout to be a safe one, for everybody. So we may need a part two. We may need you to come back after we've had a couple of months and see where we're at. And it'll be interesting what the dialogue or the conversation would be, after, 3 months from now, hopefully, or even in September, what that looks like. So I want to thank everyone for joining us today. I hope you enjoyed our Power Hour and our conversation with Dr. Gunness. We will continue to have many other Power Hours every Tuesday at 1 o'clock, different subject matters, and I hope you'll join us. We do have one more here. Is there a list of SJU studies for us to think about?
Studies in what sense?
What sense, Alan?
I'm sorry.
That's okay.
I don't want to
What
cloud
sense?
fidelity. What was the question? I didn't hear it.
You wrote, is there a list of SJU studies for us to think about?
Yeah, so as an inspiration for us to perhaps contribute in some creative way, are there a list of subjects that are currently being studied as a thesis or as a research project that we could just think about? And perhaps we More is better sometimes. Some of us we have varied expertise and varied interests, and this is an inspiring hour that might lead us to better contribute.
Brilliant question. Thank you for sharing that. Thank you for opening the discussion on that. I think there is a dramatic need for that, especially from the public health program. We are the experts. We've been doing this. We know how to what to look for, what the factors are. We know our communities in our backyard. That's what makes St. John's. We're the only public health graduate institution in Queens. Queens is our backyard. We work with the agencies here. We know them well. I'm in discussion with Amherst Hospital treating physicians at the ER. I'm in discussions with them about looking at some of the data, looking at some of these cases, trying to dissect this and to make sense of it. I think there's a lot of potential for us to sort of focus on what we can do to save our community, Queens, in our backyard and help our university and beyond.
There's a field of pro bono graduate assistance available. For example, I, for one, have credentials that might be of use to this subject, and I'm sure I'm far from alone. So just a thought, there may be a way of communicating to the community that here's some examples of what we're doing. Do you have an interest? And just exploring that in an intuitive way.
That's a great example. I wouldn't know how that would work, so I'll leave it up to Susan as a subject matter expert to guide that process.
Okay.
I think that's a good.
Susan, if I can add to that, there are several psychology faculty members and graduate students who are actively doing studies on the effect of the COVID virus on both patients' mental health as well as the mental health of the rest of us, who are obviously stressed out beyond belief. So to answer that question, yes, there are, in the psych department, there are people who have taken this opportunity to conduct research on mental health issues, which are many.
That's interesting because I wanted that as one of our other topics. So if you have someone that would like to do a power hour conversation about the mental health area of the pandemic, I welcome them.
I gave you that.
You did? Oh, thanks. It's so bad. Well, on that last note, you have a final word for us, Dr. Gunness.
Stay safe. Mm-hmm. Keep your ears to the news. Be informed, and try to make as informed decision as you can as we try to battle this virus.
Thank you. And everyone, please stay healthy, stay well, and we'll have another cup of coffee next Tuesday. Thank you.
Thanks,
Have a good day.